It's Rome and JP is on set with me today. Hi JP, and welcome to our second episode of Homefront Unplugged. Now we realize, JP, that Trinidad and Tobago, we're in a dire strait right now, in that we are in a state of emergency, things are going crazy, and now we are seeing cases where COVID-19 is hitting home. Before, and I will be honest with you, personally last year, I saw it on the news and it was very distant to me because I didn't know anyone personally who actually contracted the virus or who died from the virus. Now I know numerous people who have contracted the virus. I know people who have died from the virus. I know people who are in the hospital right now fighting for their lives. And now we are in a different situation. What do you think about that now?
Well, now they're saying rooms, the numbers have names. Before, you're right, we used to see like 1, 2, 1 died, 2 died, but now you have to see the names. It's not about 15 dying. It's about named persons there. Some person out there, some Husseins, some Charles who's not making it. And we have to see that. We have to realize the numbers have names.
They do. They do have names. Now I know people personally, as I said, that are fighting for their lives. And this is what this episode is about, right? This is why we decided to do a Homefront Unplugged today. To touch home, for you to know. Because I'm sure you at home may know someone who has either passed away, and we must say condolences to all of the family members that had a loved one that passed away due to COVID-19 virus. So today on set with us via Zoom, we have Dr. Karen Cox, who is an acting consultant with the palliative care unit. So welcome, Dr. Cox.
Thank you.
So first of all, let's start, Dr. Cox. A lot of our viewers at home, including myself, I don't know what is palliative care.
Okay, so thanks for having me, first of all. Palliative care is not well known, so I'm really glad to be able to explain a little bit more. Big word comes from a word meaning cloak, to kind of cover, to help, to alleviate. And it really is a whole approach to care. It's approach to caring for a patient and the family of a patient who's facing a life-threatening illness. So the patient has to have something incurable, irreversible. And it's an approach that is very holistic. It doesn't just look at the physical needs, it looks at the whole spiritual, psychological, all the needs of the patient and the family. And the way we do this is through a team, doctors, nurses, chaplains, social workers, focused on maintaining quality of life. So I think the key points are, it's an approach to care for the patient and the family facing a life-threatening illness, and it's about quality of life, comfort, dignity.
So usually, Dr. Cox, you wouldn't really have to deal with viruses like these. So this may be something new in terms of falling under palliative care, in terms of if you're dealing with COVID-19 deaths.
So, well, COVID-19 is new, but we have dealt with patients who have AIDS, so the end stage of the HIV virus. Once you're in a stage where it's irreversible, palliative care is appropriate.
Okay.
Yes, so we've dealt with viruses before, but nothing like this.
Nothing like this, nothing like this. So this is definitely new. But it's new to all of us, it's new to the entire world.
I know.
Yeah, JP. And today, Dr. Cox, we're focusing a bit on the healthcare workers to start off, because we know that the healthcare workers, we had a couple nurses on set at the last episode, and they were telling us they are facing death every day. They are seeing
really
patients.
Real room. I mean, when you see it from their point of view, you know, we think you know what's happening, but when you walk their shoes, it's a big deal. Yeah.
They're seeing it, Dr. Cox, they're seeing it every single day. And I would like to get into the mind of someone who have been dealing with this. Because in terms of palliative care, you would have been seeing it as well, where patients are, as you said, in their final stages before they pass on.
Yes. So, I mean, unfortunately, this is palliative care. This is what we deal with every day. Apart from COVID, people dying day after day on our wards, on our palliative care unit, or people in different stages of decline. And it does take a toll on us as health professionals. I mean, we have to maintain some distance because we have to care for the patients, yet we still need to do it with compassion. And that's the difficult part, because as human beings, we're witnessing great suffering. And that takes something from you every day.
And that's what I was kind of alluding to, JP, is that yes, you're a doctor, yes, you're a nurse, and this is a human being you're dealing with. So there's like a divide. I could see the mind would be torn a bit, Dr. Cox, where you're feeling it for the human being, but you also have to kind of detach yourself from this human being for your own mental stability.
But it's almost like compartmentalization, isn't it? Because that's what I try to do. I try to, and I mean, I'm not sure if it's healthy, Dr. Cox, but I try to make sure I feel, but I can't feel everything.
Right.
So what do you recommend that how do these care workers, how can they keep their distance though? That's difficult.
Yeah, it's difficult, and I think it's individual. There has to be a little bit of professional distance. We can't be weeping over everyone to the point where we are not functioning.
Right.
So I think what we try to encourage is you come through the door, you leave everything behind, you're fully present there with the patients, the relatives, you give as much as you can, but when you leave, you have to leave it behind as well.
Right, sure.
There are always patients that you will carry with you who touch you more. Maybe they are your age or your child's age, or they look like your mother, or whatever reason. But carrying those with you makes it more difficult for you to do your work.
Right.
So we have to find ways to care for ourselves when we leave the work.
Right.
What we talk about self-care.
So Karen, so I know that, can I call you Karen, or you prefer not to call me? So one question though, long ago, well, when I was younger, just a few years ago,
I've seen the youthfulness.
Still there.
I've seen the youthfulness.
So it used to be where as doctors and nurses, you'll feel like you really want to be a hero. You'll go and you'll save the day. So I used to come home, and if you saved a patient, you'd be like, success. It was all about saving that patient and not having that patient die. But I think now we realize it's different terms. It's things like it's goals of care, it's natural death. It's not about curing, or success doesn't mean I save your life. Success means I do the best for you. And that's a mindset switch, isn't it? Especially during this COVID time. Yeah?
Yes, definitely. I mean, I would say that cure is still the ideal, but it's important to know that when we can't cure, we can still do something. We can still care for the patient. And I really want to encourage us as health professionals never to tell someone, we can't do anything for you, because we say that all the time. And that's a really devastating place to be told we can do nothing for you. So to talk about the allowing natural death and the goals of care, allowing natural death means that we have accepted that the situation is irreversible. And so we have a shift. Instead of doing all sorts of heroic things to make you live longer, we're now going to look at, we accept that you will pass from this condition, and we want to make that in keeping with your wishes, as comfortable, as dignified, and how you want it to be. And we're not going to jump on you and give you resuscitation when we know that you're dying of something irreversible. We're going to make it dignified and comfortable. And that brings me to the goals of care, because the only way you can make it dignified and how the patient wants it to be is by finding out what they want. So goals of care is a discussion about what is the patient's goal. That presupposes that you've told them things are serious, that they are not going to live from this condition. And when you get to that point, you can ask things like, so if time was short, what would be important? Where would you want to be? Who would you want to have there? What do you want to do? And it's the patient's goals, always focused on the patient. What would the patient want at this time? And that's what we try to do in palliative care. And we recommend a goals of care discussion for any patient who has a serious illness. It shouldn't be when there's a crisis. So it shouldn't be when you are having a cardiac arrest or when you're being put on a ventilator. Once you have an illness that can threaten your life, COVID-19 is the one we have now, a conversation about what if should be had and documented by the health professionals.
So let me get
This
it
is
straight,
scary.
right?
This is scary.
So you're saying that if I have one of my relatives go into Cuba and I know that they're very ill, you're saying right here, right now, that we should have a discussion with the doctor and the relative before they get too bad. What do they really want if they reach that point? Yeah?
I think the goals of care discussion should be with the patient, if the patient is competent enough. If the patient is not, let's say the patient has dementia or is too ill, then a conversation needs to be had with the relatives, the next of kin, on admission to say, okay, this is what your dad has. This is what we're hoping that they will get better. But if this doesn't happen, or if your dad should decline, we need to talk about what we're going to do. What would be in keeping with his wishes and what would be medically appropriate. Because we are not going to do futile treatments. So it's not for the family to say we want X, Y, and Z. It's for us to come to a shared decision. This is what dad would want. This is what the family wants. This is what the medical team recommends. And this is a plan going forward. So not to wait on a crisis, but to discuss it up front.
Yeah, room is getting real.
You see, I put myself in the patient's shoes this time. If the doctor or the medical healthcare worker comes to me to tell me this, I would be thinking, am I not supposed to say I'm going to fight till the end?
Right.
How difficult is that? How do you convince a patient who wants to fight tooth and nail to the end that they need to accept that this is the end?
Well, then that's the point, right? It doesn't have, if I decide I want to fight, then that's my goal of care. I'm going to fight to the end. But it might be if I decide, you know what, I've had a good life. I think that's what the discussion is, to see what I want, right?
Right.
I might want to be all the way through, you know, or I might want to be, I want a smoother transition. Some persons actually want to say, here what, I'm okay with that. I'm okay to, I don't want persons on my chest and doing everything possible. I want to have it where it's smooth, nice, and calm.
But is there a way to, and I would use it in layman's terms, is there a way to usher a patient out to the afterlife? Is it like you give them medication where it's less painful and that they have a more peaceful death?
So it depends on the situation, but yes, there are ways to make sure the patient is comfortable, physically, psychologically, spiritually, and that's what palliation is about. Making sure whatever the physical distress is, we can treat that. So if that's pain, if that's shortness of breath, if that's vomiting, we're trying to treat that. The fear that I'm going to die, the unfinished business that I'm leaving behind, the spiritual distress, I'm not sure what's on the other side. For those things, we bring in the whole team. So this is not COVID, this is general, where you can bring in the team of your chaplain or your social worker, your nurses, to try and meet all of those needs and help with all that distress to make sure that they can hopefully have some comfort and closure. Not everybody gets there, but we still try to achieve that for the patients.
Okay.
And this happens over the phone room. I mean, they have to call them. That's the thing, because remember the nurse was saying in Vancouver that it's just the patients, there are no relatives, and it's just the phone they have to contact their relatives with, right?
But that's what I want to lead to now, Dr. Cox, is that how does a healthcare worker deal with telling the relatives that your mom, your dad, your sister, your brother, your significant other is not really going to make it? How is that discussion had? Because I know doctors personally who said that they have family members screaming on the phone when you tell them this. Is there a procedure, is there a protocol to follow, is there a guidance that you would like to give them at how to deal with this, how to carry across this message to a loved one?
Okay, so I can't speak to exactly what is being done. I'll just say how we would recommend.
Yeah, this is just your recommendation, yeah?
Yeah. So it's basically breaking bad news, which doctors learn in medical school, health professionals learn. There's a little acronym for how you break bad news. It's SPIKES, so SPIKES.
Okay.
And that stands for setting, perception, invitation, knowledge, empathy, and strategize or summarize. But I would just say them in layman's terms. 3 important things before you start talking. To be clear, I think, to be honest, and to be compassionate. So the setting is first. So if you're doing this on the phone, you want to check in with the person, identify yourself, find out who you're speaking to. Is this the assigned next of kin? Is this the person you're supposed to be having this conversation with? And then I think you want to find out, are they in a place where they can have this conversation with you? Are they able to talk now? I have called patients' relatives and they're at work and I didn't check in before, or they're driving. I think it's really important to check in. You know, I need to, Dr. So-and-so, I need to talk to you about your relative. Are you somewhere where we can have a conversation? So make sure the setting is right. And is there somebody else who needs to be there with you? Maybe you're home alone or whatever. And the next important thing is perception. I think it's really important, if you have the time, to find out first what this person knows. So you're not going to launch into this is happening to dad or mom, and the person completely knows nothing.
Right.
So what is your understanding so far? What have the doctors told you? Maybe they are already expecting that they're dying and you don't have that much work to do. Or maybe they think it's all perfectly fine and you have a lot of work to do to get them to what you have to see.
Yeah.
So what is your understanding? What have the doctors told you so far about what's happening? And then when you get to the point of giving them the news, you want to give a little warning shot. So maybe what I have to say might be a little bit difficult, or I'm afraid I have some bad news. So you let them know. You don't just
You prep
give them the bad news, prepare them. I think the giving the news is the part that doctors spend the most time on. And we talk a lot, and the patient doesn't hear anything after the first 3 words, which is your dad is worse, or so they shut it down.
JP is guilty of that. JP is guilty of that,
right.
definitely.
No,
I try
doesn't do
that. No, I try. I really try hard. Yeah.
So you want to be concise. Just say what you have to say. I'm afraid things are not going well, or dad is getting worse, and stop. Silence is okay. Say what you have to say and give them time to process what you've said. And expect emotion, because you will get silence, sobbing, screaming. That's okay. The person has to process. So we say, it's okay to be empathetic at this point, to name whatever emotion you hear, which is, I can see, it seems like this wasn't what you're expecting. I can hear how distressing this is for you. I can see that you're overwhelmed. Some statement that suggests you know what's going on with them.
Mm-hmm.
We would say, avoid saying I understand, because you don't understand. You're not in their shoes. And that could get a knee-jerk, angry response. Yeah. So not I know what you're going through.
Right.
But I can't imagine what you're going through. Or this must be really so hard.
Yeah.
And then you be empathetic as much as you can. And then you kind of strategize and summarize. So this is what I've said, this is what's going to happen. So the kind of housekeeping parts. I think it's just really important to set the scene, find out what they know, say what you have to say simply with compassion and empathy. And we could talk a little bit more about the empathy part, how we do that, and then close it off.
Okay, well, I was going to...
We lost Dr. Cox here, but in terms of the empathy, JP, you have ever had to make a call like this before?
Yeah, it's difficult. I must say, when she was talking about the compartment, what you do, I've seen myself do it already. When I'm at work, I just close it and I deal with what I have to do at point in time, and I take care of my doctors and their own issues, and so because afterwards they need to be debriefed, right? They're all emotional about it. So I have to stand firm and make sure I'm okay. Then when I come home, I've had times where at 2 o'clock in the morning time, I'm crying a little bit about that patient. And in the morning time, you say, you know what? You've done all you can. What can you have done differently? And if you go through that, you say, okay, I'm going to move on now. Next day, start fresh. You have to
just wipe the slate clean and leave that behind you.
A piece is always there with you, but you have to move on. Yeah.
And have you seen where patients want to get like a religious leader involved?
Yeah.
Or maybe give them like final blessings. I know, but now with COVID it would be different, because the religious leaders wouldn't be able to enter the COVID premises. So do you think it's possible to do it over the phone, or?
Yeah, well, I've seen it where you kind of invite your imam or your pastor, whoever, on the phone with you when you have like the multiple calls, and you can call that patient and actually have a session with them. I know people like, is it that hand holding just before you die, or just when you know you're gonna die? Okay, yeah. You kind of you would like to have your pastor with you, just talking to you. Yeah.
So,
yeah.
and then to leave a final memory, is there a way in the medical field that you'll do that? In terms of a final memory, like, okay, my significant other is going, that kind of thing.
Yeah.
Do they leave a note or something?
Well, what they do, they have these things called footprints, and they have handprints. So what they can do is that if you want to leave a little memo, because it's really important, if I hadn't had it's not last, like, okay, when you're leaving, say your friend is leaving you and you're just walking on the door, that last visual is what you see, the last thing, yeah? So you want it where the last thing you see is the most important aspect, the last thing you get. So you might have it where you take a footprint or a handprint, or a voice note, that person saying the last words like, hey, you know, I have loved you forever. Just remember that. That you can play back all the time, even after the funeral. You can just have that person saying, because you miss them. You think to yourself, I can't talk to them. If you get a little voice note, then you know, hey, I can still talk to them. It's really important.
So this was a very, very insightful episode for me, JP, personally. I want to thank Dr. Cox very much for giving her insight and her advice, because I know that a lot of the medical workers out there, the frontline workers, are dealing with death on their doorstep every single day. And they go out to work and they see it every day, and some of them may not know how to cope with it. Even though they might have the training, it's difficult to be in it in reality. So thank you very much, JP, for sharing your experiences as well. This has been Homefront Unplugged. I am Rome. This is JP. Another insightful episode. We hope that it helped some of the healthcare workers and you at home to understand what is taking place and how serious this situation is with the COVID-19, the virus, and this pandemic that we're going through. Also, we want to say special thanks to the PED CARES Foundation for supporting the children. So you keep supporting the PED CARES Foundation so that they can support the kids, so that we will have a great future right here in Trinidad and Tobago. This has been Homefront Unplugged. It's Rome.
See you guys. Bye-bye.
Bye. Welcome to our second episode. All right. All right?